Hello, my name is Barbara Cavanaugh. I'm the Director of the Division of Breast Imaging at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. And today I'm going to be speaking about the clinical usefulness of elastography in the assessment of breast masses. This slide is showing a fairly common clinical scenario. We have a very young woman. She has a small palpable mass. She's not exactly sure if it's new or not, and it feels smooth and firm and mobile. And by all accounts, it should be a benign fibroadenoma. And we're faced with this decision every day. How likely is it to be benign and does it need to be biopsied? Similarly, these masses in the slide are all low suspicion lesions. We have an ovoid parallel mass. We have two patients, different patients, each of whom presented with palpable nodularity that corresponded to some vaguely inhomogeneous breast tissue without a definite mass. And those of us who scan breast tissue all the time know that inhomogeneity of the glandular tissue is extremely common. And all four of these cases went to biopsy and became one of the 1.6 million breast biopsies that were done in the United States last year, of which 260,000 approximately were malignant. Now, these four cases all were malignant. We don't want to miss these. We think that the cost to these patients and to all of us is high if we miss malignancies. At the same time, we really don't want to be doing this many benign biopsies. So today I'm going to be speaking about sonoelastography for the evaluation of breast masses. And my intent is to understand how we can integrate elastography into the clinical and sonographic evaluation of breast masses in an attempt to decrease these benign biopsies but not miss any cancers. I'd like to disclose that I receive research support from Supersonic Imagine. So why elastography? Primarily because ultrasound as an imaging test has many advantages. It's non-invasive, well tolerated by patients. When we see a lesion on ultrasound, it's very simple and easy to biopsy it. We don't use injections or ionizing radiation. The equipment itself is relatively inexpensive and mobile. And if we use strict interpretation criteria for our assessment of benign masses, we will miss fewer than 2% of malignancies. Now, there is also a major disadvantage, which is low specificity. Even with highly skilled breast sonographers, the positive predictive value of a biopsy recommendation is about 10%. That means 9 out of every 10 biopsies is benign. That is a high burden for women and a high burden for society. The potential impact of elastography would be to increase the accuracy of our assessments, to decrease benign biopsies without missing cancers. And it could do that by potentially even obviating short interval follow-up of probably benign lesions, but also identifying within that category of probably benign lesions those that are actually malignant. And importantly, it could hopefully obviate biopsy of low suspicion masses, masses that we categorize as BIRADS 4A. Those are lesions that have a 10% chance of being malignant. Additionally, for the many, many hypoechoic masses that turn out to be cysts, elastography could possibly confirm that a mass is a cyst without resorting to aspiration or biopsy. Now, palpation itself, physical examination, is simply qualitative elastography. So we're taking something that has been performed in medicine forever and using ultrasound to apply a more quantitative version of it with sonoelastography or ultrasound palpation. And some of the earliest work was performed with the breast compressed and an ultrasound transducer being pressed gently against the breast through an aperture in the compression paddle. The mass is deformed by this pressure, and then the ultrasound transducer or the images record the degree of deformation of the mass in some way. Very soft lesions, as in this fibroadenoma, will become flatter and wider when they're compressed than when they're not compressed. And this measurement can be used to determine the benignness or malignancy of a mass. Today we use primarily two types of elastography: strain elastography, where manual pressure is applied to the breast, either by simply pressing down with the transducer or by holding the transducer still and allowing the patient's own physiologic motion to compress the mass. And the degree of deformation of the tissue that results is measured. Alternatively, in shear wave elastography, an acoustic radiation force is applied via a highly focused, high-energy ultrasound beam. That beam will exert pressure on the mass and cause mechanical vibrations that will then propagate shear waves. Those shear waves can be detected by ultra-fast ultrasound imaging, and the speed of propagation of those shear waves is related to tissue stiffness, and a resulting map of stiffness can be displayed. So how do we perform elastography? Well, strain imaging simply compares the ultrasound signal before and after application of slight compression. So during ultrasound examination, a mass is visualized, the appearance of the mass is optimized, the elastography program is activated, and a color map of the stiffness and softness of the tissue is displayed on the monitor. In this particular manufacturer, the ultrasound transducer is pressed lightly onto the breast. With other manufacturers, the transducer is simply held steady. And as in this manufacturer, the map is a grayscale map. The transducer is being held steady. The map will show relative opacity, which means that the transducer needs to be adjusted, or it will show a grayscale map showing relative stiffness of the mass against background. And when the appearance is like this, it means the transducer is being held in a satisfactory position. Another manufacturer utilizes a color map, and as you can see, this phantom is moving. I'm going to play that again. When you activate the elastography protocol, you press gently, actually sort of bouncing the transducer against the breast, and record a cine loop. There is a series of green bars in the image that will let you know if the transducer is being held appropriately or not, and that will help assure you that the color map that results is representative of the tissue stiffness. In these color maps, red and green are very soft, that's background, and blue is relatively firm, and you can see this firm mass against background. Shear wave elastography utilizes acoustic radiation force. So again, the B mode imaging is performed, the appearance of the mass is optimized, and then the elastography program is activated. The radiation force is instantly activated, and the color map is again recorded nearly instantaneously. The color map is going to be displayed as relative tissue stiffness in kilopascal, and there are actually quantitative measurements available, with softest tissue being in the range of 0 to 70 or 80 kilopascal, and stiff malignant tissue being anywhere from 80 to 200 kilopascal. So understanding elastography images in breast imaging. Strain images need to be obtained in a particular way to be sure that the color map will be representative of tissue stiffness. So you're going to set your region of interest box to include everything from the immediate subcutaneous fat down to the superficial portion of the pectoral muscle. The reason for this is that the resulting color map will help to determine whether the force that's being applied is appropriate or not. The subcutaneous fat should be red and green, which is soft, and the anterior surface, the visualized portion of the pectoral muscle, should be blue. So this would be considered a very high quality image, and in this morphologically indeterminate mass, which is very soft on the elastogram, it's a good probability of a benign etiology, which in this case was a fibroadenoma. However, image quality has to be good or the accuracy of assessment of strain images will suffer. And at the bottom of the screen is an elastogram which was considered non-diagnostic. The subcutaneous fat is indeed red and green, which is appropriate, but the pectoral muscle, which is immediately posterior to this irregular mass, is displayed in varying shades of red, green, and blue, which means that the elastogram may not be entirely appropriate of all of the tissue. In addition, there's a large signal void at the bottom left-hand corner of the image. Now, the mass itself is irregular and highly suspicious, and there is no question that it needs to be biopsied. But in a more equivocal case, this could affect your ultimate diagnosis. So in this particular series by Dr. Chang, these low-quality images were considered inadequate for elastographic assessment. Other images were considered simply low quality, and others were high quality. In the series of images scored low quality, they were only half as accurate at detecting malignancies than the images scored high quality. Very important to remember when we're trying to assess whether a breast mass needs to go to biopsy or not. The quality of the imaging was strongly correlated with characteristics of the mass and the breast itself. So when masses were located superficially, or when the breast thickness was relatively thin, elastography performed much better than with masses in a posterior location or with very thick breasts. In addition, smaller masses tended to perform better on strain imaging than larger masses did. Once allowing for image quality, the images will be scored according to a variety of scoring systems. The one that is primarily used, developed by Dr. Ito some years ago, uses 5 classifications. Grade 1 is a uniformly green-red image. This indicates that the lesion is uniformly soft and is a score of 1. Score 2 and 3 are varying degrees of mixtures of green and blue. Scores 4 and 5 indicate a uniformly blue mass, score 5 having blue stiff tissue surrounding the periphery of the mass as well as within the mass itself. A more simplified system was developed by a number of authors who simply graded from 0 to 2, grade 0 being uniformly green and uniformly soft, grade 2 being any mixture of green and blue, and grade 2 being uniformly blue with or without increased stiffness in the surrounding tissue. Other authors have utilized various ratios of stiffness within the lesion against background, or various ratios of area of lesion before or after compression. In this series using strain ratios, a region of interest can be placed within your mass and within adjacent subcutaneous fat, and this was found to also correlate with tissue stiffness. Shear wave elastography images are similarly obtained once the B-mode image is optimized. The region of interest is placed over the mass. The elastogram sequence is activated and a color map is displayed nearly instantaneously. The elasticity scale is displayed in the opposite color spectrum from strain imaging, where blue will be very soft, yellow, orange, red will be very stiff. And on machines that are available in Europe and probably soon to be available in the United States, the elasticity scale is actually displayed in quantitative measurements of kilopascal. And similar to strain imaging, shear wave imaging will display differences in the lesion characteristics with the elastogram. Very soft lesions will be almost indistinguishable from background tissue on the elastogram, whereas abnormal stiff masses will be larger and more irregular on the elastogram than they are on the B-mode image. Additionally, shear wave imaging is quantitative, so a region of interest placed within the mass will actually directly measure the stiffness in kilopascal, and these measurements are displayed on the left-hand side of the screen. So here are some of the spectrum of appearances of masses with shear wave imaging. Very soft masses being hard to pick out against background on the elastogram, and other masses having varying degrees of light blue to shadings of yellow, indicating increasing stiffness, and masses that look larger and more irregular with an elastogram of yellow and orange and shading into many shades of orange and red. There is a signal void within this large irregular cancer, which I'm going to speak about a little later. So authors have reported in varying degrees of detail about their findings, but overall the authors report that benign masses have elastographic scores that are softer than malignant masses, and the authors who have looked at varying strain ratios and area ratios have also found that benign masses are softer than malignant masses. However, in breast imaging, we really need a more specific definition of when to biopsy and when to follow. So I took a look at the research in a little more detail. Again, researchers have shown improved ROC curves when they add elastographic assessment to B-mode features, but how that translates into clinical day-to-day breast imaging is not as clear. So using these results in clinical practice, remember that many times interpretation with B-mode ultrasound is completely straightforward and there is no need to use elastography at all. When we see a classic simple cyst, that will always be a simple cyst, and we don't need elastography to help us call that normal. When we see an irregular spiculated hypoechoic mass, that is highly suspicious, and that will always need a biopsy, no matter what the elastogram shows. However, many times B-mode ultrasound presents us with diagnostic dilemmas, mostly for masses that are low suspicion. And in these cases, a variety of ovoid hypoechoic masses, all of which are cancer, we would like to biopsy all of the ones that are going to be malignant, but if possible, we would like to exclude the many cases that look exactly like this that turn out to be benign. Here is a busy slide showing results of various strain imaging clinical trials. They all measured sensitivity, specificity, accuracy, and positive and negative predictive values. The number that is most useful to us in breast imaging is sensitivity, how likely to pick up cancer, and negative predictive value, how likely is the tool to exclude the possibility of cancer. A word about how we practice breast imaging in the United States. For 20 or 30 years, the threshold to perform biopsy in screening mammography has been 2%. And that was a threshold that was set when screening for preclinical breast cancer was initiated. Every screening trial has to have a threshold below which you ignore things and above which you intervene. And breast imaging simply chose 2%. And when Dr. Stavros and his investigators published their work on the sonographic evaluation of solid masses, they utilized the same threshold for biopsy. So it makes sense in the United States that we take this threshold that has already been well established in breast imaging and apply it to elastography as well. And in all of these series, elastography alone did not perform well enough to meet our standard for breast imaging. Now, here's an investigator who very helpfully showed a bar graph of his various malignant and benign cases. And looking just at the cancers on the left side of the screen, you can see that with an elasticity score of 1, that was that uniformly green appearance, there were no cancers. At a score of 2, there were 5, and at a score of 3, there were 2 more. Many investigators have proposed a threshold of 3 to 4 as the elasticity score, above which biopsy will be performed and below which follow-up will be performed. But multiple investigators have shown similar results that with elasticity scores of 2 and 3, there were numbers of cancers, usually on the order of 10% of their series. So for us, that won't work. And here is the results of another investigator who lumped together the elasticity scores of 1 and 2, which is not so helpful for us because it's starting to look like the threshold of 1 to 2 is very important. Nonetheless, you can see that in the middle table, tabulating the benign and malignant results against elasticity score, these soft lesions, score 1 and 2, included a substantial number of cancers. What we don't know about all of these cases in all of these papers is what the morphologic characteristics of these soft cancers were. Because we know, as I said, that a morphologically abnormal mass, a mass that would be characterized as BIRADS 4B or C or BIRADS 5, is going to go to biopsy regardless of the elastographic scoring. So if these false negative elasticity scores had abnormal, highly abnormal BIRADS appearances, they would go to biopsy anyway, and they would then not be false negatives. And that's what a lot of investigators have started to do. Again, a number of studies that tabulated benign and malignant against elasticity scores, but did not utilize the morphologic assessment as another criteria. So for these soft cancers where elasticity was false negative, we don't know what they looked like morphologically. We do know from these various series, and this is just a different way of displaying the data, that overall elasticity scores of 1 contained very few cancers. Scores of 2 and 3 started to have increasing numbers of cancers. What we can also see from this data is that the benign lesions, lesions that turned out to be benign, comprised the multitude of cases in most of these trials. And here is another investigator, increasing numbers of cancers in score 2 and 3, but none in score 1, and again none in score 1. So I'm going to concentrate on this elasticity score 1 and see if we can add that to our morphologic assessment to decrease our benign biopsy rate. And here is a series from Dr. Cho, who is one of the investigators who has started to correlate elasticity scores against BIRADS appearance. Now, in his series of about 75 or so cases, I've tabulated the cases that were BIRADS 3 and BIRADS 4A. I did not tabulate BIRADS 4B, 4C, or BIRADS 5 because all of these are going to go to biopsy, and I don't think we need to pay attention to what their elasticity score is. But in this subcategory of BIRADS 4A masses, none of the cases with an elasticity score of 1 were cancer. As soon as you go to score 2, you start to see some cancers. So it seems reasonable that using a cutoff of score 1 to score 2, elasticity score 1 with BIRADS 4A, do not biopsy. Elasticity score 2 or above, take it to biopsy, is going to decrease a lot of biopsies without missing any cancers. And in this particular series, half of their masses that went to biopsy were BIRADS 4A. The other half were 4B, 4C, or 5. And of that half that were BIRADS 4A, half of those could have avoided biopsy using an elasticity score of 1. So although we're applying a very narrow category of elasticity score against a very narrow category of BIRADS assessment, we're actually encompassing the majority of masses that go to biopsy. And in this series, we would have avoided 20% of all biopsies by utilizing elasticity. Again, just to show Dr. Ito's information again, he did not utilize his BIRADS assessments, but at a score of 1, there were no cancers. Another series using strain ratio rather than elasticity score found that strain ratio generally correlated well with tissue stiffness, but it did not eliminate all cancers from the BIRADS 4A group. 1 out of 23 were malignant. That's an unacceptably high miss rate, and we would probably not correlate strain ratio with our BIRADS assessment. Now, the opposite has also occurred, and this is a very important potential contribution of elastography. We know that when we categorize a mass as BIRADS 3 and send it to follow-up, we have approximately 2% odds that that mass might be malignant. So about 1 in 50 of them are malignant. It would be better to find those prospectively and biopsy them rather than finding them at follow-up. And in this series, looking at a number of masses that went to biopsy, 3 of the BIRADS 3 lesions were upgraded to biopsy based on their suspicious elastography appearance. And if this holds out in other trials, this is another useful application of elastography. Shear wave elastography has had limited publication, but of the 48 masses that were studied in this trial, 28 were BIRADS 4, and of those, nearly half had elastography scores in the benign range. So if elastography had been utilized in addition to the BIRADS assessment, half of these biopsies could have been avoided and none of them were malignant. A much larger series is awaiting final statistical analysis and publication. That's going to include just short of 2,000 masses and promises to show similar results. So the outcome that we hope for is that of these similarly low suspicion masses, these are BIRADS 4A, they're not completely circumscribed, but they're not highly suspicious, both likely to be benign. Elastography looking benign might take this fibroadenoma out of the biopsy pool and put it into follow-up, thus avoiding a biopsy, and at the same time show that this similar 4A mass is very stiff and send this appropriately to biopsy. So avoid a biopsy of a benign mass, but not miss the cancer. Elastography with shear wave imaging similarly can take a low suspicion but not typically benign mass, this is BIRADS 4A, with a completely soft uniform elastogram, could appropriately send that to follow-up rather than biopsy. And here's just another set of cases with negative shear wave elastograms. B-mode appearance is BIRADS 4A. These were all benign at biopsy, and if elastography is utilized with a completely normal result, these could be followed safely without missing any cancers. Conversely, if a mass has suspicious B-mode features, it needs to go to biopsy regardless of the elastogram. In the case on the left with strain imaging, the mass is irregularly lobulated. There is a completely indistinct margin along one side. This is at least BIRADS 4B, probably BIRADS 4C. Even though the elastogram is a benign score of 2 and many investigators would send this to follow-up, the B-mode appearance by itself requires that this be biopsied. Similarly, the case on the right with shear wave imaging is an irregular, inhomogeneously hypoechoic mass with shadowing. This is a BIRADS 4B or 4C appearance. This would go to biopsy even though the elastogram shows soft tissue. The most stiff area is less than 70 kilopascal, which would be classified as benign. But we don't use elastogram only. We use elasticity plus BIRADS appearance. And in fact, a BIRADS appearance that is suspicious like this, we don't use the elastogram at all. We send this to biopsy. What about non-simple cysts? These are an increasing problem in practice as ultrasound technology becomes very high resolution. More and more fluid-filled structures are displaying lots of internal echoes, thus appearing complicated rather than simple. A lot of these go to aspiration, and if we had a tool to distinguish these hypoechoic masses that are complicated cysts from actual solid masses, a lot of intervention would be spared. Strain elastography does show some different characteristics of cysts against solid masses, but early work showed a lot of variability in appearance. However, a recent series suggested that there is an interesting aliasing artifact that occurs with fluid-filled masses. The appearance of blue and green and red near the posterior surface of a lesion was highly suggestive of a cyst in this series. And in shear wave imaging, fluid has an interesting characteristic in that it does not propagate shear waves at all. So fluid in an elastogram generated with shear wave imaging will have a kilopascal value of actually 0. It will be a signal void. Potentially this can allow confident identification of hypoechoic masses that are non-simple cysts and spare them from going to intervention. Here are some earlier elastograms using shear wave imaging showing the hypoechoic mass empty of signal against a soft background, and another indeterminate hypoechoic mass showing complete signal void against a soft background. Both of these were cysts. And more recently, on equipment that we have been using, we can see signal void against a uniform blue background. And this uniform blue background is important to be sure that the signal void is fluid, not signal void within some abnormal mass, and has been highly reliable in correlating with a cyst. Not all signal voids are fluid. On the left is an irregular hypoechoic mass with intense acoustic shadowing, and the elastogram shows a large area of extremely stiff tissue with a central signal void in the mass itself. We're not exactly sure why there is a signal void. One theory is that the center of the mass is so stiff that the shear waves propagate so fast that they're not visible to the transducer. Another possibility, notice all of the attenuation, that there may be so much attenuation of sound beam in the center of the mass that the ultrasound transducer cannot pick up any signal at all. Whatever the reason, what makes the difference between a suspicious mass and a cyst is that the background in the presence of cancer is highly abnormal. On the right is a lobulated hypoechoic mass. The elastogram shows uniform blue background, no evidence of stiffness in the tissue, and a signal void in the middle of the mass. And this is what you look for when you're going to call something a cyst. Background has to be normal. Again, a large, high-grade invasive ductal carcinoma. This was all solid. This was not necrotic on B-mode imaging. On color flow, there was color everywhere within the mass. So it's not tissue necrosis. It's some combination of either attenuation of the sound beam itself or shear wave signals that are so fast that the transducer can't pick them up. So in summary, elastography shows great promise for assessment of breast masses because it may improve the specificity and the sensitivity of breast ultrasound. Elastography results must not be used alone, however. They must be used in combination with grayscale image characteristics. Specifically, it appears that an elastic score that is very soft may avoid biopsy only when the morphologic appearance is low suspicion. In other words, only when the mass is graded as BIRADS 4A. If a mass is graded as BIRADS 4B, 4C, or 5, which are more suspicious appearances, those masses need to go to biopsy regardless of what the elastic score is. In addition, elastography has the potential to take lesions that we already follow, BIRADS 3 lesions that have a less than 2% chance of being malignant, and possibly elastography can find that 2% that are malignant and upgrade them to biopsy. In addition, elastography may be useful in distinguishing the increasing problem that we have with non-simple cysts appearing as hypoechoic masses. If elastography can pick out the masses that are actually complicated cysts from the solid masses, that will spare a lot of intervention. Thank you very much.